So we're going to break up the neuro talks by topic. This one's on Alzheimer's disease or Alzheimer disease. The pharmacology is almost less important than some of the other elements, but we'll talk predominantly about the pharmacology, but we will touch base about some of the other elements of the disease as well. So let's start with a case. So Arthur is a 73-year-old man. He lives with his wife, who they've been married now 47 years. He has 4 children. 2 of them live in town. 2 of them are out of state. And he's a retired history teacher. For the past 9 months or so, he's noticed he has a much harder time remembering his friends, what their names are, and also phone numbers. He's just having a bit of a hard time. Now, one of the challenges is that all of us tend to have less crisp memories as we get older. And it's always that fine line between that minimal memory impairment of aging and actual Alzheimer's disease or dementia. Arthur, however, for the past 18 months old, his wife has noticed that he's forgetting the news, he's miscalculating his checkbook balance, and he's also neglecting his hygiene needs, and he's really confusing his kids and his grandkids' names. So obviously, when someone is confused like this, we have to go through our usual differential diagnosis process. There's a number of different things that can cause confusion. If he has a relatively sudden onset or sort of physiologic confusion, that's referred to as delirium. And delirium can be caused by pages of lists of different problems. Electrolyte changes are a common reason. Infection, especially urinary tract infection as people get older, especially in long-term care facilities. And it's important to remember that you can have delirium on top of dementia as well. So if someone has a short-term impact on their cognition, we need to think about delirium. There's a laboratory assessment, there's a whole workup for delirium, which goes beyond what we want to talk about today. Other things that can cause more chronic confusion, Parkinson's, or more accurately, usually Parkinson disease now, multi-infarct dementia, or vascular dementia, which is basically a whole bunch of small strokes, Lewy body dementia, which is often very difficult to differentiate from Parkinson disease because they have similar symptoms. But even low thyroid and also anemias. These probably are more technically deliriums, but because they come on more gradually, they do seem to be more of a chronic issue. But you know, after extensive laboratory assessment, maybe imaging, and also cognitive testing, he is determined to have Alzheimer's disease, or what is sometimes referred to as senile dementia of the Alzheimer's type. I think we're getting away from the term senile just because it is kind of a value judgment. So what causes Alzheimer's disease? We think that there's probably a genetic component. We know that if people live long enough that the prevalence goes up to 80% or more, so it definitely is age-related. But there's people that never get it. I saw a patient in the office yesterday that's 94 years old, and he is very crisp and cognitively completely intact. So it's hard to parse that out. So the plaques and tangles that happen with Alzheimer's disease are sort of the major characteristic. Those things, those amyloid plaques, cause the cells around it to atrophy. You get a decrease in the neurotransmitters in the brain, especially acetylcholine. And the symptoms that you see may be related to the part of the brain. So the frontal lobe is emotions, the parietal lobe is memories and speech, the temporal lobe is perception of time, and also some memories. And then the occipital lobe is vision. It's a simplistic way of looking at it, but not without merit. Most people with Alzheimer's disease do have most of their issues in that temporoparietal area. And really the temporoparietal area are where memories are laid down. And so they can access old memories, but basically the record button is broken. If they were recorded years ago, they're there. If they happened yesterday, they really could not record those and lay those down as memories. There is a frontotemporal dementia, which goes beyond, again, what we're going to talk about today. But as we get to later courses, we'll learn more about the various types of dementia. So what can we do? There's really a very limited armamentarium for Alzheimer's disease type medicines. The cholinesterase inhibitors are sort of the mainstay. They have a real but very modest benefit. Memantine or Namenda, which is an NMDA receptor antagonist, does have merit and benefit. And then Axona is a medical food, which we'll talk about. So the first Alzheimer med that came out was Cognex, and Cognex unfortunately was not selective enough for the acetylcholine receptors in the brain. So it basically hit all of the acetylcholine receptors in the gut. It caused extreme diarrhea, caused a lot of side effects, was not really a useful medicine. So the next generation, the Aricept and the Exelon, are much more specific to the brain. They do also cause some side effects elsewhere, nausea, bladder changes, heart irregularities, but they are really much more specific for the brain. Now, another treatment that is used is Namenda, which is a NMDA receptor antagonist. It is mostly approved for moderate to severe Alzheimer's disease, used to be just severe, often used as an add-on to the anticholinergics, to the cholinergic agonists. The cholinergic agonists have a relatively modest benefit. They will slow down the progression of confusion. They will allow it to stabilize, if you will, but unfortunately when you stop them, the person goes back to where they would have been had they never been on them. So they really don't stop the progression of the disease. They just seem to keep those acetylcholine levels up a little higher for a longer time. The Namenda, the NMDA receptors, still not terribly well understood. We know that other antagonists of the NMDA receptors are things like amantadine, which is used for Parkinson's disease, dextromethorphan, which is a cough medicine. Interestingly, if someone has a head injury and you give them dextromethorphan, it seems to decrease the severity of the head injury. Ketamine, which is usually an anesthetic. We use it predominantly in children just because it seems to be better tolerated. Unfortunately, these kids, you have to let them wake up really slowly or else they get very agitated and sometimes even aggressive. PCP involves the NMDA receptors as well as some other medicines. So NMDA receptors are basically glutamate type receptors, and we'll talk about that in a minute. I did want to also mention that Namenda also seems to block some other receptors, and they may even be agonist antagonists for these receptors. And that's the other thing with all of those medicines, the PCP, the ketamine, they're probably not going to be specifically targeting a single receptor. They're probably going to be hitting a number of different receptors. So the Namenda, the 5-HT3 receptors, the serotonin receptors, these are the ones that the Zofran and the ondansetron type drugs hit, so they decrease nausea, may have some other benefits as well. The nicotinic acetylcholine receptor, number 7, interestingly, it seems that this may be the place that the majority of the Namenda effect actually happens. It may not even be an NMDA predominant effect, just because when you block 7, it seems to upregulate its production even above what it would normally make. And we think that that may be one of the reasons that the Namenda helps with Alzheimer's as much as it does. Dopamine receptors, dopamine is where the antipsychotic meds work. Unfortunately, even if it does have benefit on this receptor, it does not decrease agitation, and so if a patient does have agitation, they're probably going to need major tranquilizer, antipsychotic type second generation med. Sigmaergic, that's the lowercase sigma there, the what looks like O prime, is a new receptor which has been discovered fairly recently. We're not really even sure what they do. We know that the Namenda gets into those receptors. We think that maybe some of the side effects that Namenda has may be related to the receptors, but I think that's really a stay tuned kind of thing. So getting back to glutamate. So the NMDA receptors predominantly take up glutamate in their normal function. We know that balanced amounts of glutamate really do provide a happiness and sense of well-being in the average human being. We know that it improves memory, it helps with learning. We also know, however, that excess glutamate can cause even nerve cell death. It is actually the brain's most prominent neurotransmitter. It's the one that's around the most. It's excitatory. It is a precursor for GABA, and GABA, of course, is the neurotransmitter that's involved with benzodiazepines and barbiturates and a number of different medications. And GABA, of course, is the body's and the brain's primary inhibitory neurotransmitter. So conditions that are associated with defects in glutamate receptors, ADD, pain, autism, diabetes, Huntington's disease, you name it. Some of the really major serious things are on here. I really think that the next 20 years are going to be spent trying to understand glutamate. I think that glutamate's going to be kind of the serotonin of your generation. Umami is the fifth taste sense that's been discovered, which is also related to glutamate, monosodium glutamate. But the glutamate as a neurotransmitter is going to be studied and probably understood far better over the next 15 to 20 years. As you can see on this slide, there's lots of different things that it's related to: migraines, autism, so on and so forth. So it'll be a fascinating time once we fully understand glutamate. So right now, Alzheimer's disease is a case where, sort of the pathophysiology is not well known. Even what we know about it really only makes a very little difference. The pharmacology has a very limited benefit as well. Slows the disease, but very modestly. They're fairly expensive drugs. They have fairly extensive side effects. I actually don't use them very often, but I almost always offer them to patients and families. Some patients and families really want to try. Others really don't see the value. So most of the care for Alzheimer's is really based on functional behavioral interventions. Exelon is a medical food. Now, medical foods don't have to be approved by the FDA, and so they can make all sorts of different claims. Interestingly, when you see these kinds of medical foods on television, it'll say causes weight loss, does this, does whatever, and then at the end it will say not making any sort of claim for medical benefit, not approved by the FDA. So, you know, they can make all sorts of kinds of claims. They launched this product in 2009. Initially, it was about $110 a month. Now it's down to about $69 a month. It's really based on a single study. You know, the benefit was pretty modest, even on that single study. So I would encourage you, before you use any of those kinds of things, to really delve into them. Getting back to the acetylcholine agonists, Exelon is one of the more common ones used. It can also be used for Parkinson's dementia. A lot of patients with Parkinson's will actually develop a dementia related to their actual Parkinson disease, not related to Alzheimer's disease. The estimates are interesting. I've seen estimates of about 50% of the patients with dementia really being Alzheimer's. The others are either vascular dementia, Parkinson's dementia, or some other variation. So even though the lay population, when they see dementia, they equate it with Alzheimer's disease, that's probably not really an accurate thing to do. 3 steps of the patch going up on the dosing. The benefit, as you can see, there's 13 areas, 7-point scale. There was about a 0.1 improvement compared to a 0.2 decline after about 6 months. Maybe a little bit more in Parkinson's disease. They're about $60 to $150 a month. Previously, they had been more expensive. The cost is coming down. But, you know, the benefit is pretty modest, although some people are very happy to get any benefit that they can. So the other thing that I wanted to mention is this BAN 2401, which actually is in the news. It's a new experimental drug which seems to slow the cognitive decline even more, and actually has evidence that it decreases the amyloid plaques. It's pretty early in its development, basically just finished phase 2 trials. They'll be going into phase 3 trials. Some medicines that hit phase 3 trials have great human benefits. Others actually have little or no benefit. Obviously, if they're looking at actual amyloid plaques, it's a animal model, and they're sacrificing the animal to look at those because there's not a great way to measure amyloid plaques otherwise. So this is a quick and dirty intro to the pharmacology for Alzheimer's disease. Like I say, there's several other talks for neuro.